everyone, welcome to ResearchMD.com. Another great presentation today. Another big topic in endocrinology. Okay, we've been doing a series of lectures on endocrinology. We covered all the hormones in the posterior pituitary. Now then we went the anterior pituitary. Today's our topic is acromegaly. Yesterday we talked about the growth hormone, the structure and how does it function and all that. So today we're going to teach you everything about acromegaly. Now, first thing we have to look at the definition. Chronic progressive disease characterized by excessive secretion of growth hormone and IGF-1. Okay, let's look at the physiology a little bit one more time. Let's go back to the hypothalamus, and it's an anterior pituitary hormone, right? Hypothalamus, what happened? You got growth hormone releasing hormones secreted from the hypothalamus, and they come through the hypothalamo-hypophyseal portal system, and then come up here to the anterior pituitary, and then it stimulates the production of growth hormone. Okay, growth hormone is inhibited by a growth hormone inhibiting hormone called somatostatin. That's also important. Okay, now let's look at what are the little bit of epidemiology. Again, it's a rare disease. That means like 1 to 9 per 100,000 in the USA. Most of the people present in the third decade, let's say like 30 to 45. And the other thing, the important thing about growth hormone, we need to understand, like, when does the excessive growth hormone production start? If the growth hormone, like excessive growth hormone production, before the closure of the epiphyseal plate, okay, and then it's called actually gigantism. That's where like most common in the children. If the epiphyseal plate is closed and the growth hormone excess, that's acromegaly. That's what happened in the adult. Okay. So it's very important to know the difference between acromegaly and gigantism. Gigantism is more children, acromegaly is more in adult because the epiphyseal growth plate is already closed in adult, okay? Now we talk, let's look at about, we talk about the causes. Let's look what are the causes of acromegaly. And let's start with the primary growth hormone excess. Okay, so again, it's a excess in growth hormone. Which one? You got pituitary adenoma, you got pituitary carcinoma, extrapituitary tumor, familial syndromes like Mann-1, McCune-Albright syndrome, familial acromegaly, Carney syndrome, and all of this could cause primary growth hormone excess. Remember that, okay? And then you got extrapituitary growth hormone excess like pancreatic islet cell tumor, lymphoma. It could be like iatrogenic causes. And the last one, you got growth hormone releasing hormone excess, which is kind of bronchial carcinoid, small cell lung cancer, medullary thyroid cancer, pheochromocytoma, adrenal adenoma, and all of this cause like growth hormone releasing hormone excess. Okay, so 3 major categories we need to know. One is primary growth hormone excess, and the next one is the extrapituitary growth hormone excess, and then finally you got a growth hormone releasing hormone excess. Okay. And now let's look at the clinical features, like what will be the clinical features you will see in the patient. The main thing, direct tumor effect. There is like tumor, and how does it, mainly it can affect the optic chiasm, right? That can be visual defect. Visual defect can happen, corneal palsy, got headache, hypopituitary, and this is the major direct effect of the tumor expansion. Now, then you have soft tissue changes, increased skin thickness, you got soft tissue hyperplasia, hyperhidrosis, you can have like acanthosis nigricans. So if I'm writing a board question or an examination question, I can bring in acanthosis nigricans because you can put always like a picture, dermatology picture and write a question, okay? And bones and joints, you have frontal bossing, arthropathy, osteoarthritis. Always remember carpal tunnel syndrome will be the one of the finding, or they can write, if I'm writing a question, I always kind of bring in carpal tunnel syndrome. Now the other thing, cardiovascular effect is also important. You got diastolic heart failure, okay? And biventricular hypertrophy is common. Metabolic effect, impaired fasting glucose, insulin resistance, so you can have diabetes and increased triglyceride, but the total cholesterol can go down. Now, respiratory features, this is like, you can have like upper airway obstruction, sleep apnea, macroglossia. This is very common. That's again, macroglossia and sleep apnea could be another examination question. Visceromegaly, any of the organs can get enlarged because growth hormone can affect any part of the body, right? All these big organs can enlarge, like tongue, thyroid, salivary glands, liver, spleen, kidney, prostate, all of this could be enlarged, right? So now we have to look at how do we come to the diagnosis. Again, a little bit complicated, but you have to do a systematic approach to come to the diagnosis, right? Let's start up here. First thing, what do you have to look for? Always look for the clinical features of acromegaly. What are the clinical features? Right here, all of this kind of thing. Once you have any of these clinical features, then you start your investigation. But the first thing you have to do is measure growth hormone or IGF. We just don't measure growth hormone, because growth hormone could be elevated. Remember, yesterday we talked about it, like in sleep it can go up, exercise can go up, stress it can go up, a lot of things can go up. So it's not a good idea to measure growth hormone. Don't pick that. You measure what? First you measure the IGF-1. So you measure your IGF-1. If it is normal for age or sex, I mean, IGF level can go up to from like 50 to like 800, but there's a table for yesterday when we talk about the growth hormone physiology, we mentioned it. So go back and really look at that table. So each, between 15 to 20 is higher. When you get older, IGF level can come down, right? So if it is normal for age, sex, you forget it, no acromegaly, the case closed, right? Now, let's say you have the clinical features, you measure the IGF, it is increased, and what is the next step? That's when you have to do this oral glucose tolerance test. You do like 75 grams of glucose, wait 2 hours, and then you measure the growth hormone at that time. If the growth hormone is there is suppressed already, because we know glucose can suppress growth hormone, right? So what do? Less than 1, then you go back, no acromegaly, case closed, goodbye. Right? Let's say up here you do the oral glucose tolerance test, you measure the growth hormone, there's no adequate suppression, it's greater than 2, then you have to be worried, right? Next thing, once you do that, then acromegaly is going on. Next thing is you have to look at the pituitary. What do? You do like a pituitary MRI with and without contrast. Okay, just don't write MRI of the brain. You have to say specific. You need to ask the radiologist to look for. So pituitary specific MRI with and without contrast you do, right? If there's a pituitary mass, then it's growth hormone secreting, right? Become the pituitary gland. So it's the growth hormone secreting pituitary adenoma. So you got your diagnosis, case closed, right? Then you have to think about treatment. So let's say if you do the pituitary, right, and then pituitary looks normal, maybe like a very small size, then you have to think about the extra pituitary causes of growth. We talk about the extra pituitary growth hormone excess right here. That's our thing next. So you do a CT abdomen, chest, and then you look at the extra pituitary, the cause of acromegaly, and that's what you come up with your diagnosis. Okay, very important to systematic, but don't go with the growth hormone first. First IGF-1. Okay, now how do you treat it? First, always pick surgery. We can resect it, surgery. Sometimes you can be too big or cannot resectable. Then you have treatment option, medical therapy. What are they? Somatostatin analogs, which is octreotide, you can use. And then you got dopamine agonist, cabergoline, growth hormone receptor antagonist, pegozafermin, and all of this could be used. But again, number one is always surgery, right? And then let's say all of this doesn't work, then the last step is the radiation therapy, okay? And then, how do you follow up these people? After the surgery, you check a growth hormone level, and then after 12 weeks, you check the IGF-1, then you have to do a pituitary MRI, and then after annually, you have to check the IGF-1. Annually, you do an MRI of the brain, pituitary specific. Don't forget it. Just don't write MRI of the brain, okay? So, let's go back and let's take a big look at our whiteboard. This is the beauty of whiteboard. You can see everything very clear on this thing, right? So what do we have? We have the definition right here. We know that look at the epiphyseal plate, and if it is before the closure, you call gigantism, right? In the adult, what happened? This is the main thing. You got acromegaly right here because the epiphyseal plate is already caused, right? And then we know it's rare. And third, it's good to know the third decade, 40 to 45 years, usually presentation. You look at the etiology, the causes, mainly you got primary growth hormone excess, you got extra pituitary growth hormone excess, you got the growth hormone releasing hormone excess. Those are the three main categories, my friend. And then we talk about the clinical features. The most important thing is the direct tumor effect. You got optic chiasm sitting right here, right? That can compress because of the tumor, and the visual field defect, cranial nerve defect, and then headache is very common in any of these people with the pituitary problem, hypopituitarism. And soft tissue, we talk about skin tag, acanthosis nigricans, don't forget it. Bone and joints, all of this, make sure you remember the hearing loss and the carpal tunnel syndrome, because sometimes cardiovascular is very important, diastolic hypertension, and then you got impaired fasting glucose. Again, remember sleep apnea, respiratory syndrome, upper airway obstruction, another board question, my friend, and visceral megaly, growth hormone. Where does it affect? Any part of the body, any organ can get bigger, right? Now come up with your diagnosis. What's the first thing you have to do is look at the clinical features right here. You found there is clinical features concerning, we needed to start investigation. The first thing is you do measure IGF-1. If the IGF-1 is normal for age and sex, forget it, no acromegaly, right? If it is elevated, you go do the oral glucose tolerance test, right? And if it is then you measure the growth hormone after 2 hours. If it is less than 1, that means it's already suppressed. Don't worry, it's not acromegaly. If it is greater than 2, then you have to start investigating again. You go with the pituitary MRI, and after the pituitary MRI, if it is a pituitary mass, then you can say it's growth hormone secreting pituitary adenoma. If it is no mass in the pituitary, then you have to look at the extra pituitary causes like CT of the abdomen, chest, and come with the diagnosis. And the treatment always picks surgery, okay? And then make sure you follow up with IGF-1 and pituitary MRI. Thank you so much for watching. We'll be back with another presentation soon. Goodbye.